We'll begin by looking at the liver. The liver is a structure that is very interesting. So it's located at the right upper quadrant of of your abdomen. And here's some structures that we'll talk about. First of all, there's this biliary tree that takes bile from the liver into the intestines, and the pancreas is here. And then so bile just go from the liver into the small intestines, and the pancreas join together and they secrete their content. And gallbladder is right here. That usually store the bile here like that. There's another structure too that you should know about, and it usually is portal vein. It's called portal vein. So it takes blood from the rest of the GI tract back to the liver. The liver also has its own artery that supply it. So I'll just put it here like that. It has its own arteries that go across the liver and contain blood that supply the liver. So as you can see, the liver is a vascular organ. Was going through a lot of blood, especially the portal vein, taking over 75% of the blood back to the liver, and then it goes into the inferior vena cava and go back to the heart. So this is the basic structure of the liver. It take all the blood from the GI tract back into the inferior vena cava, into the heart. It make bile, and it store the bile in the gallbladder. This is where the gallbladder is located. And then when you eat fatty food, the gallbladder secretes bile and go into the GI tract and digest the fatty food. And so this is basically basic function of the liver. Unfortunately, things can happen to the liver, especially alcohol. Alcohol is very toxic to the liver, such that when you drink alcohol, what you do is it goes to the liver and damage the liver. And then but the liver can heal itself. And so it forms scar tissue. The healing forms scar tissue. You go and drink again, you form scar tissue here, scar tissue here, scar tissue here. You get to the point the liver cannot repair itself again. So these scar tissue start pushing on these veins, this portal vein. And it can also push on the duct. And this is the common bile duct. That contain the bile. When it happened, we call it all this, we develop what we call cirrhosis, because there's too much pressure in the liver. The liver is so scarred down, and that is what developed into cirrhosis. So scarring of the liver, basically that's what it means. And this can lead to portal hypertension, because this portal vein is being pushed. It cannot send all the blood back to the liver, and therefore you have more blood in the portal system, and that is what we call portal hypertension. We'll talk about it, but this is just briefly to give you an idea what it means to have cirrhosis of the liver. It means your liver is being scarred multiple times, that it doesn't do its function anymore, and it has too much pressure in it. So that's what it means by cirrhosis of the liver. Basically, the function of the liver, there's a few things the liver does. Like I told you, one, return blood to the heart through the inferior vena cava. So you take all the blood back to there. When you eat, all the nutrients get into your blood, and the liver need to send into the heart so they can go to the rest of the body. We can pump it back to the rest of the body. So that's one function. The second function is responsible for making proteins. It's make most of the proteins in your body. And one of the biggest protein is albumin. So the liver make proteins in your body. And then one of them is albumin. The third one that it does is also secrete clotting factors. So like when your blood is too thin and it need to clot, when you catch yourself, the liver make clotting factors. There's a bunch of them, but the common one that I want you to pay attention to is factor 2, factor 9, and factor 10. These are what we call vitamin K factors. So this is what, when you take coumadin, this is what it affected. Coumadin affect these factors, and they have vitamin K dependent factors. So it secretes these clotting factors. The next one it does is it detoxify chemicals. So detoxification of chemicals. So if you take any chemical, most drugs go to the liver and to be broken down. And so detoxification is very important. That's why when you drink alcohol, which is a chemical, it goes to the liver and the liver tries to break it down, but unfortunately, it damaged the liver. And number 5, we talk about bile. Usually your hemoglobin contains some breakdown of your red blood cell contain hemoglobin, which when it breaks down, you have bilirubin. And the liver used it to make bilirubin, which it tried to get it out of the system. And it go into your GI tract, and you can either pee some of them out, you can, and some of them go into your stool. And then your body get rid of it. So it get rid of bilirubin, and you need it to digest fatty food. Okay, and it also control the portal system. So if there's too much pressure in the portal system, then everything build up. So these are the 6 key function of the liver. They return blood to the heart, to the IVC, protein synthesis, clotting factor synthesis, detoxification of chemicals, metabolism of bilirubin, and a portal system. And this can be select all questions they can ask you, which is what is expected. Based on this pathophysiology, I believe your exams is all pathophysiology. If you understand the pathophysiology of a disease process, all SATA questions will be easy. So expected findings, we already talked about it. So now we're going to see what is expected. Because the liver detoxify chemicals, one of the chemicals is ammonia. If the liver, you have a liver cirrhosis and you cannot break down ammonia, you have high level of ammonia. So the liver cannot detoxify chemicals, especially ammonia, and you will have increased level of ammonium, and you have encephalopathy. The second one, it does the clotting factors. Because it make clotting factors, if the liver is defected, it cannot make these clotting factors, which I told you, factor 2, factor 7, factor 9, and factor 10. These are the clotting factors the coumadin attack. Therefore, if you can make them, it look like you're on coumadin. So your INR is going to go up, or your PT is going to go up. The other thing that can happen is we talk about bilirubin. Because the liver metabolize bilirubin and let it go into your GI tract. If there's cirrhosis, the biliary duct can be obstructed, and it cannot metabolize, it cannot push it back into the GI tract. So it go into your system, systemic circulation, instead of staying in your GI tract. And therefore, you have high level of bilirubin. How does that present? Patient is going to become yellow. So when you see patient, they will look yellow. And then what else they will do? Their eyes will sclerate. They will look, when you look into your eyes, their eyes, they look yellow. The other place you can look if they have dark skin is under their tongue. So under their tongue, or mucous memory of their mouth, it will look darker. You see yellow stuff over there because dark people, you cannot, it's hard for them to see yellow, except to become jaundice. You can see it on your skin. Your skin doesn't look yellow because of the darkness. So you can look into their eyes or under the tongue. And then one of the symptoms they complain about is pruritus. So severe itching from the bilirubin. So pruritus. So you can see how you can teach patients to cut their nails so that they don't scratch themselves and wear gloves. This is education question right here, over here. Then I told you about liver making protein. Well, protein is what ensure that it keep the oncotic pressure in your vascular system, such that when you you don't have enough protein, fluid will leakage of fluid into extracellular matrix. And when fluid leak, what do you think? When you have fluid leaking into the extracellular matrix, what do you think will happen? You develop what we call edema, that's fluid out of the intravascular space into the extracellular space. Fluid also can leak into your abdomen. And that is what we see in these people. It look like they're pregnant, but they have ascites. It's outside the GI tract because fluid is leaking. They accumulate fluid, and so they gain weight. So these are all some of the things you see in the patient who have cellulitis. Then I talk about platelets, how it can affect platelet function. This is from portal hypertension. When the liver is cirrhotic, that there's pressure too much, the portal vein cannot take blood back to the liver. And therefore, what is going to happen? There's too much blood in the portal system. Unfortunately, the spleen send blood into the portal. So if this is the portal system, going to the liver, the spleen is here. The spleen send its blood into the portal vein. If there's a blockage here, if there's too much pressure here, blood will back up into the spleen. So the spleen will get bigger. So you have splenomegaly. When the spleen get bigger, it affects platelet function, hypersplenism. So they may affect the level of platelets in the system. So you have less platelets in the system, and so patient will have bruising or petechia. So this is an expected finding. So low platelet causing bruising, petechia, protein deficiency leading to ascites, edema, weight gain, bilirubin causing jaundice, pruritus, clotting factors decreasing, increasing INR, and this also will cause bleeding, excessive bleeding, and ammonia leading to encephalopathy. Now, I want to go into details with what it means to ascites. So this is the GI tract, okay, the intestines here, and the liver is here. So all the fluid that leak will be in the patient abdomen. It's outside the GI tract. And so they will have, they will look like a big belly, like that. They have ascites. They have ascites. Why does that happen? It's because of the albumin. Like I said, the albumin is involved with the oncotic pressure of the blood. If there's less albumin, fluid will leak out. It can leak out to any space they want, your leg and mostly the abdomen, because there's a lot of space there. So it can contain too much, a lot of fluid in the abdomen outside. So that's what we call ascites. So you have this as ascites, and the patient who, what you see usually is you see increase abdominal girth. And you can see that the patient will gain weight. If you have too much fluid, yes, you're going to gain weight. If there's fluid leaking out, what do you see? In your extremities, you see edema everywhere. And then all this thing is going to affect the patient. And so at the end, if they have too much fluid in the abdomen, your diaphragm sits here. So you watch for questions about respiratory symptoms. So diaphragm sits here and the lung is here. So the lung get pushed up and they may have dyspnea on exertion. They may have respiratory issues just because of the fluid in the abdomen pushing on the liver. How do you treat them? So the treatment for ascites, think about it. They have too much fluid. They don't have proteins, and they're leaking fluid into the extracellular, extravascular system. Well, meaning get rid of the fluid. So remove the fluid. How do you remove the fluid? You can we give them Lasix so that they can pee the fluid out. But there's one medication that really help is spironolactone. Spironolactone, that is adoptone. So it's very specific for patients who have cirrhosis. But you give them diuretic, you give them Lasix in addition to spironolactone. Adoptone is a potassium sparing, and Lasix will lead to losing of potassium. So you see, you can balance it out. So you're losing Lasix, but then you're using potassium with Lasix, but you give them potassium sparing with adoptone. So that means you have to watch their potassium. So get rid of, remove the fluid by letting them pee it out using diuretic, or you can do paracentesis. But what is the main problem? It's because the liver cannot make what? Albumin. So give them albumin to keep the fluid in the intravascular system. But you should expect to see that this patient, if you remove the fluid, they're going to lose all the fluid that they have. So they can become hypotensive. They can be symptomatic. So you may have to give them some fluid back. You got to watch a change in hemodynamics. That means hemodynamics. That means their heart rate and their blood pressure. They may be something they can give you for who do you see first? Somebody who has paracentesis. Now his blood pressure is low, his heart rate is high. It's because you remove all the fluids that they were using. And so there's a change in the hemodynamics. So you pay attention to that. That can be a priority patient. And so this can also be a SATA question. They can give it to you. And so this is how you manage. One more thing. What do you think? A patient who is retaining fluid is fluid overloaded. There's one electrolyte that like to hold on to fluid. And if patient has too much fluid, we tell them to avoid it. and that is sodium. So you tell them to limit or restrict their sodium level to at least less than 2 grams a day. And before we talk about this, let's, I know I mentioned something about paracentesis. So the paracentesis, this is the patient with the gut and the fluid all over. So how do you do the paracentesis? Remember, this is a temporary removal of fluid to help them. So it's temporary, it's not permanent. It doesn't solve the problem. The main problem is the albumin and the liver that is defected. So if they ask you a question, paracentesis is not forever, it's a temporary problem. Patient need a consent. You cannot just do it. They need a consent to do this procedure. So you have to consent them. The other thing that they do is they have to avoid. They have to void. So they need to void before the procedure, and so that you don't injure the bladder. The reason why you do that is because to decompress the bladder. So they should void before the before you do the procedure. After the procedure, you should check their weight because their weight is going to change. So you weigh them, and then you should check their abdominal gate. Like I told you, there will be hemodynamic changes. Their blood pressure, you got to check it. You got to check their heart rate. You got to check their Ascites because of the acute change in fluid shift. Your body doesn't like that. During this procedure is usually high Fowler position. And these make the fluid go down so that you'll be able to remove it. This is another reason why you have to pee so that you don't injure the bladder. Now I told you the liver detoxify chemicals. So this detoxification is very important for liver function. It's ammonia. So if the liver cannot metabolize the ammonia, it become a problem, and that lead to encephalopathy. The patient will show signs and symptoms of B sharp, my prioritization technique. They become lethargic. They will be confused. The patient is lethargic and confused, well, they will have slurred speech. They can't talk properly. And if they have a slurred speech, confused and lethargic, they can go into coma. So this is what they have. That's why. And among all of this, being in coma is a priority symptoms. This is why you have to treat it. You have to treat it right away. There's something they always ask when you talk about hepatic encephalopathy and this problem, Cirrhosis. And they can ask you as a question, what does it mean? Or as a selector apply, or patient who is encephalopathic, what do you see? And what it means is the flapping tremor, but it's the flapping, when they stretch their hand. When they stretch their hand start to flap back and forth. And that shows that they are encephalopathy. That's a physical finding. How do you treat this? And this will go into pharmacology. The best way is to take away the ammonia, but how would the liver doesn't work. So what the treatment is, give them lactulose. This is a laxative. It's lactulose. There's another medication you can use, Rifaximin. Rifaximin, Rifaximin. These are the two medication, but most people know lactulose. But there's another medication, Rifaximin. If you don't have lactulose, you can use Rifaximin. Lactulose, you have to know some stuff about lactulose. you don't just give them the lactulose, okay? You titrate the medication so that they can get 2 to 3 bar movement. 5 bar movement, you got to decrease the dose of lactulose. The medication, you have to know how to give it, okay? You can give it with milk because it doesn't taste good. It tastes really, really bad. You can add it to a fruit juice, or they take it in empty stomach. So this is something teaching question they can ask you. So milk, fruit juice, or they take it in an empty stomach. You cannot give a patient lactulose. One thing you have to look for, this is very important. If the patient cannot have bowel movement, then you cannot give them lactulose, because the only way you can know the lactulose is working is by them having 2 to 3 bowel movement. So avoid in a patient who has constipation. If the patient has constipation, don't give them lactulose. Or if they have ileus, don't give them lactulose. That is a trick question. You should avoid it. If they have constipation or they have bowel obstruction, if they have obstruction, any form of obstruction, bowel obstruction, ileus, or constipation, avoid lactulose in this patient. Okay, this medication, it can be given orally, and because it tastes bad, you got to add it to milk, fruit juice, or take it empty stomach. If the patient doesn't want to take it, then you can give it as enema. There's enema formulation for lactulose. So you can give it to them in the enema form. So this is a key things you have to know about lactulose. Any medication you give, you got to see if it's working. So they can ask you about therapeutic effect. So if the patient has encephalopathy and you give them lactulose, then their hysteresis will decrease, or their mental status may improve. So their mental status will improve. If they're confused, if they are lethargic, they get better. If they're confused, they get better. If they have slurred speech, they get better. If they are coma, they are no more in coma. If they have hysteresis get improved. 2 to 3 bar movement, once again, is the therapeutic effect. So if they having 5 bar movement, you got to cut down the lactulose to 2 to 3 bar movement. So these are therapeutic effect of, and then the last one, you should expect the ammonia level to go down. So if I give you a lactulose and you are encephalopathic, therapeutic effect means ammonia level is down. You're having 2 to 3 bar movement. Your hysteresis is gone. Your coma is getting better. You don't have any slurred speech anymore. No more confusion, and you are no more lethargic. One last thing about lactulose. You have to know that because of the bowel movement, their potassium level goes down, and your sodium, they get dehydrated. So pay attention. This is one of the B-sharp electrolytes. So this can be a priority question they ask you. Giving a patient a lactulose, what is your priority? So potassium goes down. You know, hypokalemia is not good. And their sodium goes up because of the laxative effect of lactulose. So watch for their potassium, which goes down, and sodium, which goes up. Anybody on lactulose is very, very important because of the dehydration. It's a laxative, so they have multiple bowel movement and they lose all their potassium, and then they become dehydrated, and their sodium will go up. So they can ask you if somebody is on lactulose with low potassium, what do you think? Yeah, it's dehydration. Now, Let's go back to the liver again. So this is your stomach, okay? And the liver is here. When you have liver and cirrhosis, there's some vessels that used to be vestigial. That means you don't have it anymore. Your body doesn't need it. They open up, especially some vessels in your umbilicus. There's some vessels that is already obliterated. That means it's been closed. But when you have cirrhosis, it starts to open. We call it capital medusa. And your hemorrhoids also get bigger because the blood cannot go to the liver anymore. There is some vessels near the border portion, lower portion of our esophagus. This is your esophagus. They start getting bigger, and that's what we call varices. They are varicose vein. You don't need to use the word varicose vein, but we call them varices. And they can bleed and you can die from it. So people with cirrhosis have varices. And the number one place is the esophageal varices. You can have it at your belly button, which is the capital medusa, or you can have it at the inner area where your hemorrhoidal varices. You can develop it there over there. Mrs. Or bright red blood. So a patient vomiting blood. If they give you a patient vomiting blood who has end-stage liver disease, that is your clue that somebody with cirrhosis coming with end-stage liver vomiting blood. So vomiting blood, that is your clue that a patient has esophageal varices. So upper GI bleed. So somebody with liver disease come with upper GI bleed. This is an emergency. So it's an emergency. You do your ABC by doing sharp. So basically, the first thing you do is airway protection because they vomit and then they can aspirate and die. So number one, any patient they give you with the GI bleed due to varices, number one, first thing you do, airway protection. And how do you do that? You lay them on the side. Lay on the side. As they vomit, they can lay on the side so that they don't aspirate. They may need an NG tube, but you, the nurse, cannot put in NG tube because of the varices. This has to be done by the doctor. So they may need EGD, that is endoscopy, and to put the NG tube in. So if they give you select or apply question, don't choose NG tube. You cannot insert NG tube unless you say the MD insert NG tube. Yes, I'll pick it up. If the MD insert the NG tube and the EGD, yes, that is fine. But you, the nurse, don't put EGD for somebody who has esophageal varices and is bleeding. These patients, because of the bleeding, you got to make them MPO. Of course, they're bleeding, they cannot eat. So if these patients have to be made MPO. Anything that happens in the GI tract, most of the time when you come in, we try to make you MPO because you may need surgery. Because they bleed, because of the bleeding, sometimes they may you need to decrease blood flow through the vessels. So we have this medication called octreotide. Octreotide. It's a splanchnic vasoconstriction. So basically the GI tract, it decreased blood flow through the GI tract, and that decreased blood pressure in the varices. So that will slow down the bleeding. You can also use a beta blocker. We usually give them beta blocker to decrease the vascular resistance in the vessel. And so this is another place where you can use beta blocker. But the beta blocker we use here is non-selective beta blocker. So propanolol and nadolol. Talk about BAM are beta, they are beta selective. So beta selective, that means they bind to B1 receptors of your heart. There's B2 receptors on your lungs because you have two lungs. And then BAM just bind to B1 receptors. Non-selective propanolol and nadolol are the only non-selective that bind to B1, B2. And so they can decrease blood flow through the GI tract. These patients also need PPI to decrease acid secretion. So this is a select or apply in terms of patient who comes in with upper GI bleed due to esophageal varices. Of course, this patient will need blood, type and cross, transfuse. Evidently, they may need other surgeries that need to be done, but these usually control the bleeding really well. Sometimes the bleeding cannot be controlled, but there's a medication, there's something we can do to temporize, and it's called SB tube, okay? And this SB tube, it has three components. Down here, this is below, there's a sphincter here. So esophageal sphincter, so the stomach balloon is below the sphincter. It also putting pressure on the varices, and the esophageal balloon putting pressure here. And it has three lumens. So one lumen here, another lumen here, and here. And this is the gastric balloon here. This is the esophageal balloon. And this is what is sucking the stomach from any fluid in the stomach. So three balloon outside, three lumens and two balloons. So you inflate this, and that inflate the esophageal balloon. You inflate this, and that inflate the gastric balloon, and that put pressure in the varices, and they stop bleeding. And so this is what happened. This is the treatment in case the patient continue to bleed, SB tube or Blakemore. The problem is these balloons can cause ischemia. And so you have to monitor them. You have to make sure the pressure in the balloon is not too much, but it can migrate. So it can migrate into the upper airway, and it can cause obstruction. It can dislodge, and it can cause obstruction. That is the common symptoms: obstruction, airway obstruction, which they like to ask. So anybody with SBT tube should get what? You should have scissors available at bedside. And when they have any evidence of airway obstruction or aspiration or anything like that, all you need to do is to cut the balloon, cut the balloon as fast as possible, and then you pull it out. Otherwise, they're going to have airway obstruction. So any airway symptoms of airway, you need to have a scissors. So this is a must at the bedside, and just cut the balloon. And when you cut the balloon, it's better not to deflate them, because deflating them takes some time. But when you have scissors, you just cut it, and then everything would deflate. All the two balloon would deflate, and you pull it out, and that relieves the patient obstruction. So that is SBT tube. Simple way of remembering: SBT tube has three lumen with two balloons, one for gastric, one, and then the esophageal is above the sphincter, and the stomach is below. And the common symptoms is airway obstruction. So, and this is where they can ask you so many questions. In terms of medication, well, anything that can affect the liver, they should stop. Especially Tylenol, we can get it over the counter easily. And so they pop a lot of Tylenol or aspirin. So they should avoid any medication that is nephrotoxic, like statin. This medication can affect the liver, and TB medication too. Most of them all affect the liver. So you got to be careful, monitor the level when you're taking those medications. Their diet, they need to have low sodium diet. They should not strictly avoid protein. No, they need some protein. So don't tell them not to eat any protein. They shouldn't restrict protein completely. They need a high calorie diet because they need some energy. Um, because they cannot use bilirubin in the GI tract, they should take low fat diet. This is the reason why they should have low fat diet. Even though their bilirubin is high, it's not going into the biliary system. So low fat diet, high carbohydrate diet to give them energy. So they need high carbohydrate, high calorie, low fat, and some protein. As you saw from the Blakemore, they can have varices and they can bleed. They can develop hemorrhage, and they will bleed. So if they have blood in their stool, they should call the doctor. And then, of course, think about it. I mean, the most common thing that is affecting the liver, sometimes alcohol. So no alcohol, avoid alcohol, ETOH as soon as possible. And so this is all about the liver, so there's so many questions they can ask you: education questions, teaching questions, treatment questions, what you expect. This is a client with known um, end stage liver disease present for annual assessment. Which assessment finding and education are expected or appropriate? Select or apply. So basically, he's saying this is a select or apply question. Patient has end-stage liver disease and he came for annual assessment. What do you expect to find, or what education is appropriate for this patient? So as we talk about, they give you AST, ALT is 3 times normal. I told you the liver, the main liver function test is either albumin or AST, ALT. This is what usually get destroyed when you drink. Your liver cells break down, and then the level goes up. When every medication that you take, anything you do to the liver cells, they get inflamed and they get mad. You have AST and ALT goes up. That's how you can tell it's a liver problem. AST and ALT goes up. So this is an expected finding. Avoid protein in diet. Like I told you, they shouldn't restrict their protein. So this is wrong. Take frequent rest with activities. Yes, they have ascites, they have low energy, they cannot make protein. So frequent rest is good for them. INR of 2. The liver cannot make clotting factors, which are 2, 7, 9, and 10, and other protein like protein C and S. These are all made by the liver. But these 4 is what can affect your INR. So you expect a patient with end-stage liver disease to have INR of 2. They have severe pruritus. This is due to high bilirubin, which is an expected finding. They have thrombocytopenia, and this is due to portal hypertension. This portal hypertension, too much pressure in the portal system, such that blood back up into the spleen, and you have spleen get bigger. And when the spleen get bigger, it suck all platelets. It suck all the platelets. So you have thrombocytopenia from hypersplenism because the spleen get bigger. And so this is expected. Of course, they have hysteresis due to high level of ammonia. Albumin of 4. This is a normal albumin. You don't expect the albumin to be normal in the end-stage liver disease. So this is wrong. On laces and spironolactone, I told you because of the ascites, you need to get rid of the fluid, and you give them Lasix. But the laces that they need, the diuretic that they really like is spironolactone because they spare potassium for them, and therefore this is suspected. So 1, 2, so 1, 3, 4, 5, 6, 7, 9 are the right answer. The last question is a client present with upper GI bleed, so he's bleeding due to esophageal varices. Which prescription the nurse expected from the healthcare provider? So it's a SATA patient question. Like I told you, SATA questions are not, I know it's very intimidating because you have so many answers. But the way I see SATA question is you only have one answer choice for that question. Ignore the other ones. Just ignore them. Look at one. All you have is one answer choice. Does that answer that question? Is it related to the topic? And the way to answer such a question is write down the keyword, esophageal varices. And then I'm looking for prescription that is expected. And then you can focus on each answer choice to match these three. Does that answer this esophageal varices? Is it a good prescription? And is do something I expect? And then you go down, you make a decision as you go. So don't be intimidated. GI bleed. Oh, I forget GI bleed. You have GI bleed, esophageal varices, prescription expected. So if somebody have a GI bleed from esophageal varices, what prescription do you think, or what do you think the doctor is going to do? That's all it means. You can change it in your own words. Clear liquid dye. So if patient is bleeding from esophageal varices, we got to make the patient MPO. So this is wrong. Omeprazole. So this is PPI. Yes, you need to decrease acid secretion. So this is good. Type and cross and screen. This is just make you think. Patient is going to is bleeding. Of course, is going to get transfusion. If the best way to replace somebody blood is to give them blood. So blood is good. So you need to type and cross it. Octreotide. This is like I said, this decreased splanchnic blood supply. So it decreases blood flow to the GI tract. So if something is bleeding, you can decrease blood going there. There will be less bleeding. So this is good. Flat or supine position. So if the patient is bleeding, the number one thing I said was airway. And how do you protect their airway? Lay them on the side. Laying them flat and supine will cause aspiration. So this is bad. And then Nadolol. This is a beta blocker. So we give patient with esophageal varices beta blocker. And the beta blocker that we use is non-selective beta blocker. And there's only two you should know, propranolol and nadolol. So this is right. So you have 6, 4, 3, 2 are the answer. Thank you very much for your time. I hope you enjoyed. If you like this video, go to the YouTube and like it and put a comment so that I can grow my channel. I'll be making more videos for you guys, and I hope this is helping you with your exams. Take care of yourself and have a great day.